Testing 1, 2.
So we do this gel plus it and move the body. So you have it. You not email it to everyone. The whole year, like every. Yeah, like what
Testing 1, 2.
on the 4th of November. Yeah, but I don't think it was but the dates, the topics don't necessarily need to, but the actual days that you. So that was false. That was.
This is going to be much less highbrow compared to Mike's talk, but this is going to be the sort of basic things you need to know for the exam, okay? So thoracic and lumbar fractures, because when you're an orthopedic surgeon, this is the sort of stuff that you will see a lot of. Okay, so I'm going to talk about the anatomy, I'm going to talk about evaluation, we're going to talk about trauma and osteoporosis, classification and surgery. The surgery bit is going to be the bit where the exam boys are going to talk about the approaches, okay? So the key thing is, the spine can be divided into sort of 3 areas. There's the thoracic section, T1 to T9. There's the thoracolumbar section, which is T10 to L2. And then there's the lumbar section, L3 to L5, and there's the sacrum as well. So 90% of all the fractures occur at the thoracolumbar junction. The reason they occur there is because this is a transitional zone, and where you go from a very stiff thoracic spine to a very flexible lumbar spine. 10 to 20% of fractures are burst fractures, so they are less common. So if we talk about the thoracolumbar junction, the T10 to L2 should be a straight section of the spine. So the thoracic spine has got a kyphosis, the lumbar spine has got a lordosis, but T10 to L2 should be nice and straight. So it's a transitional level, and you can see the facet joint orientation. Facet joint orientation is somewhere in between the orientation of the thoracic spine and then the lumbar spine. Okay, so you can see that there, that the thoracic spine, it's designed to sort of resist flexion. The lumbar spine is allowing flexion. If you look at the orientation, it's more AP. So evaluation, what do we do? So in an exam, they'll ask you, how would you evaluate this? You need to quickly race through the, resuscitate according to ATLS protocols. But as a clinician, you need to consider associated injuries, whether they have a spondyloarthropathy, whether they have a coagulopathy. The patients that you see at Southmead with injuries, generally, the people that get really bad injuries generally have spondyloarthropathy or have a coagulopathy. You see them more than just in the general population or in clinics. These are the guys that have very stiff spines that end up fracturing and getting bad injuries. And often they're elderly people on warfarin or aspirin or clopidogrel. And the things you then need to think about is there a neurological deficit? Is there sacral sparing? In other words, is there rectal tone? Are they in spinal shock? In other words, is the bulbocavernosus reflex present? So starting with you guys, what's the bulbocavernosus reflex?
So it's a reflex you elicit by doing PR exam, and either doing catheter tug, or you can squeeze the penis in the male patient, and you get a reflexive squeeze on PR. And if it's
you see that sort of an anal wink is what they say. Yeah. Okay.
So if it's present, it means the spinal shock is over.
Yeah.
And that is the true neurological deficit.
Yeah.
So if it's not present, they're in spinal shock, and you can't say that they've got a definitive spinal level at that stage.
Yeah. So that's exactly it. So then the other thing to be aware of is pressure ulcers. People that have a cord injury will get pressure ulcers, so you need to watch that straight away. And then now it's a case of radiographs, CTs, and MRIs. So you generally, patients that end up going to theatre generally have a combination of generally have all three of those. And what the MRI tells you, so most patients coming into Southmead will have a CT scan of their chest, abdomen, pelvis, but what the MRI scan will tell you is what the ligaments are doing, whether there's a disc herniation, and other soft tissue injuries, whether there's hematoma in the canal. So in general terms, general classification, there's the Denis classification, there's the AO classification, and then there's TLIX as well. The question is, why do we classify? Because by classifying a fracture, you can then understand the mechanism and it can help you guide the treatment as well. So this is the Denis classification. This is the sort of thing that you learn as an SHO, and there's 3 columns, and the posterior column is in line with the PLL, there's 4 types of fractures. There's compression fractures, burst fractures, there's a seatbelt fracture, and fracture dislocation. Then you can see it here. These are the different types of fractures that you see with the Denis classification. But what's the limitations? The problem is different mechanisms have the same appearance when it's a severe injury, and it doesn't consider neurological injury or what the ligaments are doing. So as a result, sort of a North American sort of study group put together TLIX, which came out in 2005. So often when you're doing the exam, you often think, what other papers should I know? This is actually one of those papers. If you leave today, just make a list of TLIX, and there's one more paper that I'm doing. You don't need to know the papers in depth, but just with this, all you need to know is 3 things: fracture morphology, integrity of the posterior ligamentous complex, and whether there's neurology. And it's a sort of thing which, when I was doing the exam, Mr. Gargan at Children's Hospital used to say, you need to know 1 line about everything, but you can't know nothing about something. And this is the sort of thing where it's like a way of classifying these injuries, because you know most of these fractures are at the thoracolumbar junction. And these are the 3 things you need to know. Okay? So these are the morphological descriptors: compression fractures, translational rotational fractures, or distraction. And then whether there's a neurological injury or not, they can be either intact, in which case they get 0 points, whether there's a nerve root injury, whether there's a cord injury or cord equina. And then looking at the posterior ligamentous complex, they're either intact or injured or suspected or indeterminate. And then it guides treatment. So you can see here they've suggested a surgical approach, but the main thing is less than 3, non-operative, more than 5, operative. And then if they're 4, you can operate on or you can manage non-operative treatment. And from my experience, most of these fractures, you classify them and they're 4, and then it still doesn't help you, but at least it's something that you can document. And this is the sort of thing that it's just useful to know, and it's something to be aware of going into the exam. Now you get a lot of smartphone apps, and you just plug this all in, and you can see there's a subaxial cervical spine injury, there's TLIX, and there's a SIN score. So often smartphone. The other classification system is the AO classification system. Mike, are you aware of the AO classification system, or do you use it regularly?
I use it when we put the information in spine roots.
Because
that's the only time.
Yeah, because it's one of those things where the only person I knew who used to use it regularly was Ian Nelson. He would classify it and go A, B, C. But in general terms, A is a compression injury, so failure of the anterior structures. B is a failure of the posterior structures, and C is a failure of all the elements leading to either dislocation or displacement. So, again, it's one of those things where coming up to the exam, just be aware of it, A, B, C, and then there's different subtypes. So you can see there's A0, A1, A2, A3, A4, B1, B2, B3. Again, no one is going to expect you to know that, but just be aware of it. So if someone says, how do you classify a fracture? You can say TLIX, you can say the Denis classification, you can see the AO classification, then they'll move on to the next thing. So 1 line about everything. Now, the key thing about fractures is with spine fractures is actually almost any fracture you can treat non-operatively. So when I was on fellowship in New Zealand, we had some guy that came on holiday from China, and he basically sort of injured himself and was involved in a car accident. And he had multiple fractures in his thoracic and lumbar spine that were really bad injuries. And he sort of said, actually, I don't want an operation. And so we just kept him in a bed for 6 weeks, and we just bed rested him. And when he got to 6 weeks, but we only got to 7 weeks, he got on a plane and flew back to China. But the point was, you can treat any fracture non-operatively, and that's what they used to do in Oswestry as well. There was a guy called David Jaffrey who trained one of our colleagues, John Hutchinson, and all the fractures there they treated non-operatively with bed rest. Even really severe burst fractures, they would treat, that other units would stabilise, they used to treat non-operatively with bed rest. And what's interesting about it is that it shows you that you don't need to fix all these fractures. You know, you can keep them in bed, log roll them, and all these fractures healed. What are the indications for surgery? Really, the only sort of absolute indication for surgery, and this is something that Ian Harding used to grill us on when I was a reg, is progressive neurology. Other than progressive neurology, even if they just have a neurological deficit, you can sit tight and see what happens. Progressive neurology is where the neurology is getting worse, cauda equina, and I suppose a relative indication is if there's significant instability. But you know, the take-home point is that most fractures, if they don't have cauda equina syndrome or progressive neurology, you can sit tight and treat them non-operatively. So operative management. So you know, when we look at these fractures, what we generally tend to do is we often will say, get a standing X-ray, or put them in a brace and get a standing X-ray, and then you can sort of make a decision. But in general terms, what we look at is if there's significant height loss, if there's significant kyphosis. So at certain parts of the spine, you're allowed kyphosis, but if you've got kyphosis at the thoracolumbar junction, which I talked about before being straight, that's not good. So here I said kyphosis 20 degrees, and then canal compromise more than 50%. So what are the approaches? So most of these fractures we fix posteriorly, but we can also do an anterior or anterolateral approach, which would be a thoracotomy. And you expose the spine, both sides of the diaphragm. Okay, so who wants to talk to me?
Absolutely not.
What stage, have you done the MCQs or?
Yeah.
So you've got to give the approaches of. Have you done spines or?
No.
Okay. Do you want to pass or you're not allowed to pass once? Okay. Okay, that's a bad prognostic sign plan. So posterior approaches, generally there's low risk of visceral or vascular injuries. If you fix the fractures straight away, you can use ligamentaxis. So there's AO sort of screws that go into the pedicles, and you can sort of stretch them out and regain the height. And generally, we kind of go 2 up, 2 down, or 3 up and 2 down. How many screws we put into the thoracic spine, it doesn't really matter because it's a stiff part of the spine. But we try to limit how many screws we put in the lumbar spine. And sometimes when we do these fractures, we do it without violating the joint, so that sometimes you can then come back a year later and take the screws out. So that's another option as well. So, and also sometimes with you can also do a transpedicular corpectomy. So this is not really trauma, but it's more metastatic disease. So the anterior approaches. It's the advantage is you can get sort of superior neural decompressions. You can take out fragments that are pressing into the canal from the front. Something you can also instrument fewer levels. In other words, just go up and down, put a cage in. But the disadvantage is there's a significant blood loss, and some people say it may be biomechanically inferior. So, anterior approach. Who wants to do this? Who else is? So, James, or is it?
Yeah, someone listening next week.
Yeah.
So there's the transverse there, and there's a transabdominal approach.
Okay, so this is for trauma now. So this is not an ALIF approach, but it's anterolateral.
Okay. So this is going to be an extra peritoneal.
Yeah, retroperitoneal.
Awesome. I'm looking at next week.
Okay. Okay, so the key thing is, again, with approaches, and I sort of banged on about this last time, with the exam, certain things, if you don't know, they will fail you, because things like the anatomy doesn't change. So even though the bearing surfaces will change, or, you know, different technical aspects will change. Certain things like the approaches, the anatomy has stayed the same, you know, for obviously since time dot. So first thing I'd say is positioning. So what we often do at Southmead is we use a Jackson table, so a radiolucent table, and put a urinary catheter in, okay? Arm board, and we use hip bolsters and an inflatable bean bag to position them laterally. We often do it left side up. The reason we go left side up is because the aorta is on the left side, and if you have an arterial injury, it's easier to repair than if you have a venous injury, so IVC. The other thing that we do is we put a little roll under the axilla to protect the axilla as well, okay? Then what I do is take a metal marker, place it on the skin, take an x-ray, and mark out the top of the vertebral body, the bottom of the vertebral body, the back of the vertebral body, anterior of the vertebral body, so you know exactly where you're going. Then, you know, essentially, it's a very easy approach. You just cut through all the structures, and you cut, you know, you make a sort of anterolateral sort of incision like that, and then so you just need to know what the structures are. So you can see on the picture here: skin, fat, external oblique, internal oblique, transversus abdominis, and then you've got the peritoneum. And generally what we do is we push the peritoneum forwards, and you've got slices and retractors. So there's a thing called a fish slice. There's different retractor blade systems that you can put in that will hold everything out of the way. And then what you see is the psoas, and you've got the aorta at the front. And in between is the spine, and you've got hills and valleys. Pyron, what are the hills?
The hills are the vertebral bodies.
So the hills are the discs,
Okay.
okay? And the valleys are the vertebral bodies. What runs in a valley?
So, the venous plexus.
So normally rivers run in valleys, okay?
Yeah.
But in this case, there's segmental arteries coming off the aorta. So the next thing you need to do is find the segmental arteries and tie them off sort of proximally and distally. So tied off the aorta, you can see that in the picture there. You can see segmental branch ligated, okay? And then, you know, essentially you're then pushing the psoas posteriorly, and you're pushing the sort of vasculature anteriorly. And actually, when you do it, sometimes you don't even see the aorta, the aorta only falls forwards. But the key thing is to tie off the segmental arteries, and then you're at the bone. Okay, so then you can kind of do the work, take the bone away, take the fractured bone away, put a cage in. Okay, right. So anterior approach to the thoracic spine, very similar. Same setup. Mark it out with a metal line. You know, and generally, what we do is we go 2 ribs higher than the level that we want to go to. So if you want to go to T10, you take the 8th rib. Okay. Now then again, you know, you get them on the side. You generally don't need a double lumen tube to intubate them. So when you're very high up in the chest, you can do, but here you can just use normal intubation and you open up the chest. So how do you do that? You then make a line along the rib, you make an incision going almost to the midline at the back, and you know, when you start, you can make a nice big incision. You cut through the skin, the fat, and then you're down onto the rib. One of the things that you get asked is, you know, which way you take the fibers, or which way the fibers go. And I think John Hutchinson has a sort of thing where they say that, I'm going to sort of mess this up now, but what does he say? He says, you know, external oblique, he says, it will come to me, but it's a very incorrect thing to say, but it's something to do with which way the fibers go. And generally, external oblique runs down, but internal oblique, so that's right, it's, the external oblique runs downward, so it's like putting your hand down a girl's top, and internal oblique is putting your hand up a girl's skirt, but it's something like that. So that's the way the fibers run, and you attach the fibers, you take the rib out, you can use the rib as bone graft, and again, then ideally, what would be ideal is to do a retropleural approach, but invariably you end up going transdurally because the pleura is so thin. Generally, within 10 seconds, you're in the chest cavity. But when you get to the back of the spine, it's actually nice taking the pleural, you know, the pleura off the spine, because then you can see the segmentals again. Okay. So again, these are approaches that you need to know. You put retractor systems in that open up, and then you're at the chest as well. Okay. So here you can see, you know, this is a cage that we did. And often what we do is we supplement it with screws in the vertebral body, and here I've done a corpectomy. Okay, so what's a chance fracture? Pam, what's a chance fracture?
So flexion distraction,
Okay.
injury which results in sort of 3-column.
So actually, if you look it up, it's not always. So one of the myths is that it's sort of is that it's because sometimes the center of rotation is anterior to the spine, but sometimes the anterior column fails under tension as well. So it's not always flexion. Sometimes the anterior column fails under tension because the center of rotation is the seatbelt, and the patient buckles over the seatbelt. So sometimes all 3 columns can fail under tension. That's true, isn't it, Mike? It's sort of and there's 2 types. It can be bone or soft tissue, or a combination of the 2. What's the best type to have? Bone, soft tissue, or combination?
Probably bone.
Bone. Why is the bone one the best one to have?
It heals together better.
Yeah, so you can treat it in a brace, and it's reasonable to treat chance fracture in a brace if it's a bony chance. If it's a soft tissue chance, it just may not heal. And the key thing is there's a high association with intraabdominal injury as well. And often, when you get a chance fracture, often the person, the patient's in a lot of pain. Everyone goes, oh, well, that's the fracture, but often it's they're peritonic because they've had some sort of bowel injury as well. So surgery can be from the front, it can be from the back, it can be for a combination, and it can be minimally invasive as well. So here you can see this is a patient that when I was on fellowship, and what we did was, you look at this and you think, right, a little bit kyphotic. Let's just put some screws in, 2 up, 2 down. And but actually what we did was this was just fixed with a USS system. Is this good, Mike? Would you have done this or not? Would you have done 1 up, 1 down?
Are the pars fracture? I cannot see any fracture of the pars.
There's no pars fracture.
The posterior, the spinous process along the ligament.
I can't remember.
Yeah, because that's important. Because I think what you've done, you fixed it there, but this is probably the position I would have stayed anyway on its own.
Yeah.
So you haven't made any difference.
Haven't made any difference, yeah.
So
So this was like a really big sort of like Maori patients. And then what happened was we sort of watched them, and you could see they were becoming progressively more and more kyphotic. And you can see the top screws now failing. So then, I remember Peter Robertson, my boss in Angus, have you not heard of the load sharing concept? And the point was the vertebral body at the front was completely destroyed. So he should have gone, and his argument was you should have just done a corpectomy. But I think in hindsight, if he probably put 3 screws in at the back, 2 screws in below, he might have got away without going anteriorly. But it brings us to the next paper. And this is, again, one of those classic papers that's written in 1994. And it's a really simple paper. It's really bad science, but it's one of those ones that people quote all the time and you see it. So this guy called Bob Gaines is from Texas. And I think he knows sort of guys like, sort of Ian Nelson and Hutch quite well. But Bob Gaines always used to go anterior. He didn't need any excuse, and he was going anteriorly. And essentially, it's a classification system based on a very small number of patients, and they classified it according to sagittal comminution on the CT, how close the fragments were together, so fragment apposition, and then the amount of kyphosis. And essentially, if you went more than 7 and more, you should go anteriorly and do a corpectomy. Now, the other thing to be aware of for the exam, the other topic that comes up all the time that you should know is ankylosing spondylitis and the difference between ankylosing spondylitis and DISH. Both of them are really common, and both of them, they've got such stiff spines that when they break, people sort of have significant fractures. And the way to look at this is that it's almost like a long bone fracture. So if you fracture your tibia, you can't just stick a tibia in like a long bone, you wouldn't just put it in a cast, and effectively you have one whole segment here, which is one long bone, and you have one long bone there, okay? And there's an MCQ question coming up, but the key point is look for fractures elsewhere. So this guy, I was still on a locum consultant sort of contract, so I thought, gosh, everyone's watching me, I better not mess this up. And I got this guy on the table, and then when I looked at the scans closely, there was an unreported fracture here, where he just completely fractured through the front. at this point here. So this is a guy that I was fixing I was fixing this, but then I got him on the table and had another look, and I looked at the CT just as I was about to scrub up, completely hadn't consented him for this at all. So I ended up sort of fixing the main fracture. I think I then woke him up, put him in a collar, and then brought him back a week later and fixed the front, having explained to him what I was doing. But I put a plate on there. But you can see it's not even my best plate because I've kind of missed the bone there. But it was very hard, whether the fracture was to see the end plates well. This is another fracture that I should show you. This is a guy who was involved was on a motorbike, road traffic accident. When you look at this, you think there is no way in the world that he's neurologically preserved. But in the end, he ended up having this, and he had full neurological recovery. So that's a fracture dislocation. Suggests there's greater deaths in the first 24 hours, but I think that paper was skewed by the fact that there were a lot of cervical fractures that did badly, but the other two papers suggest it's better to treat these fractures early because you can sit patients up and it's better for their chests and they have less chest infections and things like that. Okay. Now, at the time, one of the other big things was minimally invasive fractures. So you could you have these sort of tubes that you put in, and you put the screws in with very small incisions, and then you drop a rod, which connects up with all the screws. But now, instead of using this system, what's changed things for us is doing it minimally invasive with the O-arm navigation. So that's that big ring, that big donut you see parked on level 2. So now we do it minimally invasively with navigation. I thought I'd quickly talk about osteoporotic vertebral fractures. They're really common. Often they have a minimum history of trauma, okay? And again, remember, you need to know something about everything. What are the different treatment options? One is vertebroplasty, which is a very cheap technique where you put high viscosity cement into the bone. So generally, I wouldn't recommend doing this for a fracture within the first 6 weeks. Probably a fracture that hasn't healed after about 3 months. Would you agree, Mike? After about 3 months? So, yeah. So when
in Europe, they're more aggressive. They do the manual.
So when the process technique came out, everybody was putting cement in, but now the indications of minute now is for sort of myeloma palliation, because cement obviously is osteolytic, so you wouldn't put this into someone who is young. And as Mike said, we generally tend to wait as long as possible. Another option is kyphoplasty, but this is much more expensive, and it involves inflating a balloon and injecting cement into the bone. The reason for the balloon, the thought process is that it can restore the shape, and also because you're using lower viscosity cement and you're creating a void and you're filling the void, it's less likely to leak. So that's the sort of thought process behind it. There are very few randomized controlled trials in orthopedics. This was one of them. And essentially there were 2 studies that were published in the same edition of New England Journal of Medicine that basically said vertebroplasty was a complete waste of time, but there were huge methodological flaws in these studies. But the problem is when a paper is published in a very highbrow journal, it's often taken as gospel. And the problem here was that there was very small patient numbers with varying different levels of age, comorbidities, smoking status, bone mineral density. One of the papers, there was no record of the levels injected or the volumes of cement injected. That's a huge thing. If you're injecting a small amount of cement, you inject a lot of cement. And in one of the studies, the placebo treatment was injecting a local anesthetic near the facet joints, and that will also have a pain relieving sort of effect. So there was no good control, and there was no good. The actual study methodology was flawed. But these are 2 studies just to be aware of as an example of a randomized controlled trial in orthopedics. So they're the sort of main bits of thoracolumbar fractures I was going to talk about. Now I thought we'd go to the MCQs now. Are there any questions?
There's more evidence for kyphoplasty, though, isn't there?
Well, again,
Because,
when you say evidence, what do you mean?
so I'm sure I was looking at, there was a paper in this month's Spine, wasn't there? There was a Japanese team, and they did a randomized controlled trial for kyphoplasty, and in terms of improvement in pain.
Yeah.
But
I think it does work. I think a lot of it is selecting patients. So selecting patients who have failed conservative treatments. I think not that these treatments are bad, but it's just picking the right treatment at the right time. And generally, for most of these fractures, if you leave it long enough, it will heal. So sometimes though, if, with metastatic fractures or myeloma, putting some cement in gives, for pathological fractures, sometimes it's a quick way of palliation and just getting them up and getting them going.
Is there any evidence for bracing osteoclastic fractures?
So again, not really. So you'll discover that Mr. Katsinius is a big fan of bracing, but the thing about bracing is that often you have, I think patients like it because you get some pain relief, but I think if the fracture is going to collapse, it's probably going to collapse anyway, and a lot of it depends on the brace and whether you wear it regularly. And I think it's very patient specific. So some patients love it, some patients just don't tolerate it. If you're very obese, no brace is ever going to fit you, and you're not going to get good control. But if you're sort of, slim person, it might be quite a good option.
The other thing is a lot of these fractures are in thoracic spine, which is a healthy state. I don't use osteoporotic fractures. I don't use braces.
Yeah.
And a lot of these elderly patients don't tolerate it. They don't tolerate the brace. I use them in the lumbar area for comfort.
Yeah.
But not,
Yeah.
not for osteoporotic, not in the thoracic spine.
Yeah.
Because it doesn't make any difference.
Any other questions?
I saw recently that anterior approaches to spine, which now we're using approach surgeons, vascular or general surgeons.
Yeah.
Is that what's happening?
Yeah, so it's becoming a bit of a sort of medical legal thing, and I think the difficulty is if you have a vascular injury, it's very difficult to justify that that you can repair a vascular injury. So at Southmead, we have vascular surgeons and extra theatre. So often we do the approach where we ring them and tell them there is that we're doing an anterior case. In certain approaches you can see on the MRI scan. So this is not really trauma. Because generally for trauma, you're straight through. When you're doing a lateral approach, you're straight onto the spine. But maybe for anterior approaches, for things like anterior fusions, certain levels are quite difficult. So 5-1 is generally reasonably straightforward in the sense that you've got the iliac, the bifurcation, and you're going between the iliac bifurcation. But L4-5 can be quite a tricky approach. Sometimes those approaches we get people in straight away to help us there. But I think what's changing is that now in medicine, someone will ask you how many of these do you do a year, and often we don't really do that many anterior approaches per year. So maybe sort of 10, 12 a year, so that's huge numbers. And if you have a vascular injury, it's indefensible if you haven't heard. So I think they're putting a stop to a lot of people in small DGHs doing anterior approaches for that reason. And also what's changed is in the old days, every DGH had a vascular surgeon, but now vascular sort of surgery is now regional. So if you're not in the hub, it's very difficult to do. Yeah.
So the RS1, we have to transfer rather than retro.
So again, most of these, it's better to go, so you can go transperitoneal, but it's much nicer to go retro. So all of these, you just move the peritoneum out of the way. Yeah, so exactly. So there's nothing that you can, so generally when you go intraperitoneal, it's because you've damaged the peritoneum. You've accidentally gone through it. So everything you can try and go retroperitoneal. Yep. Okay, should we go on to the MCQs? I had a bit of a panic this morning and I had to quickly had to ring up Andy and say, Andy Jones, ring up and send me the answers. So, should we go around the room one by one? Or how do you guys want to do it? Have you guys done the MCQs? Has everyone here looked at it? Because if you haven't looked at it, I can give you 10 minutes to just do the questions. What would you guys like? You decide. Would you like me to go one by one and we just answer it? Everyone works out the question as we go along?
That's what we usually do.
Yeah. Okay. Where do you want to start? Shall I start at the back? Or do you want to just do the exam, guys? What do you guys prefer?
We've done our MCQs really, so actually it should be everyone else.
So how should we do? Should we start at the front and just go through it? Okay, so the bottom line is, I used to get these questions wrong all the time. And even up until, I remember doing the practice UKITE exam in December. And then I was doing the MCQs in January. And I remember still getting doing these questions, even about 6 weeks before. So there's, literally just, there is no shame in getting these wrong because it's a bit of a game. Okay, so Adrian, talk me through that. What would you do there? Is it Do you want to read the question? Or you guys have to read it and then we do it like that? What would you do there? 52-year-old woman underwent a C5-6 ACDF for a cervical radiculopathy through a left-sided approach 2 years ago. Radiographs are shown in figure A. Oops. Okay, so there's no radiographs, but essentially it's ACDF. She had altered voice since this operation. Recently, the patient has developed myelopathic symptoms, including gait instability and dexterity problems with her hands. An MRI shows a fusion at C5-6 and an adjacent level midline disc herniation at C4-5 with cord compression and myelomalacia. The laryngoscopy of the vocal cords demonstrates abnormal function of the vocal cords of the left hand side. Which of the following is the most appropriate treatment for the patient?
So,
And explain why.
she's got what sounds like progressive neurology
Yeah.
and myelopathic symptoms, probably because of adjacent level disease at 4-5. And you've got an MRI evidence that shows the pathology. So in normal circumstances, you would consider operating on that.
Okay, so the 1 and 2 is excluded then, okay?
Yeah.
Okay, so what's your answer now?
You've gone on your left-sided approach, you have injured the recurrent laryngeal nerve,
Yeah.
which is the risk of doing your ACDF from a left-sided approach. And so
So what, just go for any answer and
I would say I would do 4.
Okay, so C5-6 hardware removal and C4-5 ACDF using a right-sided approach. Does anyone else here think that's a good thing to do? Why not, James?
Because you might have a left.
Yeah. It's contraindicated.
Yeah, certainly can't speak, can't breathe. So when I was an SHO, I was an SHO at King's in London, and I literally started my first SHO, or second SHO job, and the consultant I was going to work for had just been suspended, and she was an Australian endocrine surgeon, and she had a high rate of rogering both recurrent laryngeals, doing thyroidectomies. And the problem with that is if you roger both recurrent laryngeals, your vocal cords close, so you need a trachea to breathe. So generally, you go in on the same side, although it's harder, you don't want to risk rogering the other one, okay? Because it's not even a case of you'll have a bad voice, you won't be able to breathe, okay? So the answer is, the patient, and then the next question is, what about a posterior laminectomy infusion? And I think in the imaging it says, the patient has anterior compression from a midline disc herniation, therefore posterior compression would not adequately address focal anterior compression, okay? So, John Hutchinson says, it's like having a stone in your shoe and just cutting out the top of your shoe. It's not going to help. You need to take, the problem out from the front. Okay. I don't know your name, sorry.
Selena.
Selena. Okay, so this is your one, Selena. Okay. And remember, there's no shame in getting these wrong because I got several of these wrong. So an awake and cooperative patient presents to the emergency room with the injury seen in the CT scan in figure A. Okay, I will show you that in a minute. Prior to the CT scan, he had an Asia impairment scale of E. Upon returning from the CT scanner, he has an Asia impairment scale of D. What is the most appropriate first step in management? So these are the options. So come back to the answers in a minute. That's the scan. Okay, so you can see there's a bifascial dislocation.
Yeah.
Quick question, what's worse, A or E?
A.
A is worse, isn't
A
it?
is worse.
So this is that bit where Pia needs to switch the sort of the monitoring off, the recording off. But when I was in, I told you this before, haven't I? So when I was on fellowship in New Zealand, there was an American fellow who was there, and I was like saying to him, it's funny because most classification systems, A is better than E, but with Asia it's the other way around. And this guy who's from somewhere in the middle of America said, yeah, the way we remember it is A for ass fucked. If there's another thing that you take away, you will never forget Asia classification. A is bad. Okay, so now this one I got wrong. So I said, so give me your answer then. So what would you do here?
This is the one that he was talking about was this controversial area. So, I think so. It depends on how quickly you can get your MRI scan. So if you can get it now and immediately, you'd go for one and get the MRI done pre-op. But if you can't, then you'd go for, well, then either 2 or 3, depending on the surgeon's preference.
Okay, yes, so that's reasonable. So what the answer is actually 2. The answer is 2, yeah. So I looked at this and I thought, the logic of this is that he's gone from being perfect to having an ASIA score of D. Okay, so what's an ASIA score of D? Does anyone remind me what an ASIA score of D is? You guys?
So it's greater than 50% of muscles.
A power of 3 out of 5.
Yeah.
Yes, greater than 50%.
Okay, yeah, that's right. Okay, so that's a D. So it's more than 50%, isn't it? Yeah. Okay. So he's gone down a level. Their argument is he's awake and cooperative, so he can tell you if anything's happening. So you should go for 2, immediate closed reduction with cervical traction. So what they're saying is if you start reducing it, and suddenly goes, I can't now feel my legs or I'm losing function. I looked at it and I thought, actually, I'd probably do an MRI scan because for the reasons that Mike said. But what they're saying, will you guys get the answers to this?
Yeah, we can.
Forward it. Okay, it's a really long answer. I'll just read out what it says. And it says, because the patient is alert, cooperative, and sober, the next step in management is closed reduction with cranial traction while the patient is awake. And then it says,
do you have the answers one,
Sorry?
Do you have the answers document?
Yeah. So I can forward it to you, and he's got it forwarded.
Yeah, but I mean, when you can, if you want to,
Okay, yeah, so
you can run through that.
Okay, so what I'll do is I'll open it from another thing. My worry was I was actually going to flash up all the answers. That's why I.
Yeah, that is American.
Okay, so this is the answer. Do you want to do another read on that? It's a long answer. Okay, you guys happy?
Can I ask? So we're doing this, he's awake, so we're doing it as closed reduction. But what happens if you're doing the traction and suddenly his neurological function deteriorates? Do you stop? Or
Then you stop and take the weights off, and then maybe get a scan. Because what's happening then is you're either putting tension on the cord, or there's a bit of disc that is going into the spinal cord. So then you stop. But the whole point is, most of the time that doesn't happen. So I think it's one of those sort of things in medicine where one of the other things is people say don't give too much oxygen because you lose that drive, the CO2 drive or whatever. There's certain things that must have happened once. There was a case report, and then you very rarely see it ever again. This is another one where someone once must have had a reduction where the disc went into the canal, but generally it's very, very rare. But the point here is that it's more of a medical legal thing, in my opinion. But bottom line is, the way I look at it is, if you've got neurology or you've got some neurological function, you've got everything to lose. If you're ASIA A, you've got nothing to lose. You're already stuffed. So generally, what I would do is scan. And the point here is, because he's awake and he's cooperative, he'll tell you if he's losing function. And if he is, then you stop. But the other funny thing as well is that when you do these, actually, it suddenly clunks back. So you're putting more weight, more weight, more weight, more weight, and then you have to rotate the head. Did Mike tell you about how to do manipulation maneuvers? So you generally rotate it. So I had one which was a unifacet dislocation, and they say you've got like the pins in the head and Gardner Wells tongs, and you just turn the head in the direction of the facet dislocation, and then it just clunks back in. So often it's control, 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 clunk. But when it clunks, you're not in control. So then what happens if a bit of disc comes out? That isn't anything you can do. But the point is, straight away if he loses function because he's weight positive. Okay, happy? Okay, so this bit's telling you about the Asia classification system. Okay. Okay, next one. Where are we moving to? 30?
So I'd go for 5.
Okay. Someone's done his homework.
Rationale being C6 is his last functional level, and he's got complete cord injury below that level, and because he's got no sensation, no lower extremity function at all, absent perianal sensation, and he's also got intact forward cavernosus reflex, so he's not got a spinal shock.
Yeah.
So therefore he must be Asia A.
Yeah, perfect. Okay, so that's great. Everyone happy with that? Feel free to ask any questions or make any comments. So if I just go back a slide, let me just check. Yeah, all happy?
Yeah, the level, it's the first level that's screwed, isn't it?
The first level that's
Preserved.
the last level that's preserved.
Is it the
Yeah,
last level that's
yeah,
preserved?
so
Oh,
wrist-
sorry,
yeah,
good break
yeah,
every
yeah.
year. Okay. I can't do that one.
Okay, cool. So that's what we're saying here. So described as the lowest segment where motor and sensory function is normal on both sides. Okay. Okay, next one. Moving along.
So in patients with lumbar disc herniations resulting in significant unilateral leg pain but no functionally limiting weakness, surgical decompression is what long-term effects when compared to non-operative management. I plugged a guess here and I said 3 because I didn't think that surgery offered any benefit when we.
So you're right. Well, so that's what I thought was the answer as well. So there was something called a sport trial. I did this and I got this wrong. So 3 is wrong. But that's what I thought as well, because there was a study called the sport trial, which is the Spinal Patients Outcome Research Trial. And I think at 1 year, and what happens is someone does a trial, and then every year they put out 4-year outcomes, 5-year outcomes, 6-year outcomes. And apparently, when this question was done, what I was told was that at 1 year, there is no difference in sort of function and pain and things like that. But apparently in this study, it says that there is a difference in everything except for employment status. So the answer is 4. So improved outcome in pain and function at 4 years. So I didn't know that, okay? One of the interesting things with these MCQs when you come to the exam, if there is, so the examiners get given the questions while you're doing it, the examiners will also do the paper as well. And if there are questions that everybody gets right, or everybody gets wrong, or there's no correlation in terms of it's completely random, those questions get taken out. So if you're doing the exam and there's a question and you go, well, what are they going on about? You'll get questions, you'll do 100 questions, but actually you'll mark maybe over 90 of them, because examiners will go, hang on a minute, sport trial 1 said this, and someone else will go, sport trial 2 said that, and it'll get discarded. So, when you do these sort of questions, you'll always get questions that don't make any sense. They generally get chucked out, okay? Everyone happy? So that's what they're saying here. So it's a guy called Weinstein, he's editor of Spine, and it's a sport trial, okay? So no difference in work status, which is probably that none of these guys ever work again. Okay, let's go on to this one now, number 5. Hiam, do you want to do this one? Feeling brave?
Yep. Well, I've done my MCQs already, so.
Okay, well then you can do this one then. So when I was at Red, Pyam was one of the SHOs, and Pyam was brilliant because I worked with him at Bath and I worked with him in the BRI. And the one thing that I could give Pyam to do was sort out whatever we were eating. He knew every single, wherever we were at Bath or the BRI, he knew best places to get food. So
Takeaways.
Sorry?
Takeaways, yeah.
Takeaways, yeah.
So Asia B is no motor function, but some preserved sensory function. So I think 5 is the only one.
Yeah. So he's out of spinal shock. Okay.
At least half a chemo. That would be
You guys
B.
happy with that? Yeah, cool. Let's say no motor, sensory open. Cool. One of the key things to sort of point out with this table, which I never really appreciated until I saw somebody with a C4-5 fracture dislocation, is look how so normally all the numbers are next to each other. Okay, so it goes C4, C5 like that, right? But look at this point where C4 is next to T2. So one of the bizarre things is you kind of do it and you go, oh, the sensory level is sort of T4 because they're none above the nipple. But actually it's a C4 level because C4 is next to T2. It's a little quirk that when you see cervical injuries, be aware of the fact that C4 is next to T2. So it's something you don't really think about because you normally think everything is next to each other. But when it comes back up, C4 is next to T2. Okay. Right. This one here. We're up to. Should we come across to you? Yeah.
I have to read the whole thing because I haven't read them previously, I'm afraid. I have to read the whole
Yeah,
thing.
no, that's fine. Take time.
Is there a figure 8?
Okay, yep, so figure 8 is this. Okay, back to the options. So let's just quickly go back to figure 8. What's figure 8 showing? What are they trying to show?
It's got a pretty degenerative spine, but then
Yeah.
with the addition of some cervical discs that are indenting on the cord,
Yeah.
with some cord changes as well.
Yeah.
So particularly see
Which part of the cord is it? Front of the cord, back of the cord?
Okay.
Centre of the cord.
Oh, it's lighting up in the centre. That's
Yeah.
like our arms are weaker.
Yeah. So
So
they're getting
central
at
cord
cord syndrome. Yeah, yeah. Okay. So,
Um,
what do you reckon the answer is then? The wording is not very helpful here.
It's not a good question.
I think my understanding is they tend to be reasonably, they do get some recovery. Some
Okay, so recovery of what?
of our hands, I get 2.
Okay, so it's actually not their hands, it's lower the function, but hands never recover. Okay? So the answers go through it. Oops, 1 second. More likely than not, she'll regain her ability to ambulate independently. It's funny, when you speed read it, you read it as not be able to ambulate independently, but actually they're saying the opposite. So, yeah. So stepwise deterioration is myelopathy, central cord syndrome, do not gain function of their hands, and they're left with clumsy hands. And then 5, it says, central cord syndrome due to bowel and bladder function, and rapid progression is only an abscess or tumour. Okay, everyone happy? Okay, we're halfway now. Okay. So the left. Go for it.
Which one's read? Sure, I'm here for 5
Okay. So, so all of the following are attributed to the loss of supraspinal control of the sympathetic nervous system. So generally, the sympathetic nervous system does everything here except for one thing is controlled by the sympathetic nervous system. Okay.
Yeah.
Spasticity. Yeah. So that's the answer. Okay. So that's that one. So, again, a long explanation, but okay. Okay, should we go? We'll go up to you, yeah? Go for it. Number 8. In many ways, you need to just look at the answers, and then you can almost not read the question. You can almost not read the scenario. Just look at the answers, and you've got it.
I think the answer to this isn't perhaps what we do. No, actually, it is.
5.
Yeah, exactly. And essentially, the answer is so. That's the picture, and the answer is do not initiate methylprednisolone. It does not support the administration of this, and so I think that's gone out of fashion. Okay.
But in the UK, we even if it was before 8 hours, we wouldn't anyway, would we?
Yeah.
Because that's American.
Exactly.
Yeah.
Yeah. Correct. So that's why someone's just put generation. Yeah. Okay. Happy? Okay. Says.
Well, it's probably not fair asking me.
Oh, you've seen the questions. Yeah, that's right. Yeah. Moving along. Yeah.
You could have just nailed it.
24 questions.
Should say that all bloody year.
Yes.
Yeah, that'd be your day.
Yeah. So it's not spinal shock because the reflex is back. Okay. Happy?
Mhm.
Everyone happy? Yeah.
Yeah.
Cool. That's that. Okay. Next one. So you've already been told the answer to this one by Mike.
Excuse me, or,
Yeah.
It's a distraction injury. It's a reflection distraction.
Yep. Okay, well done. See that you're already, you guys are nailing it. It's sort of, Okay, good. Next one. Okay, so you need to see the radiographs, okay? So read the scenario when you're ready. Okay, so these are the radiographs. Have you got up to you there? Yeah. So what do the radiographs show?
We've got X bonds.
Yeah. Okay, so we'll go back to the question. So the key thing here is that there's, okay,
Just get CTC.
Can't do 2 and 3.
yeah, I agree, but where is it comparing the pain?
Neck pain, so do it neck first, so 3.
Yeah, that's the answer. Okay, so the thing is just to show you this right expand. Okay.
Sorry, is it interesting just remind us of how to tell the difference between dish and
Okay, that's a question for you guys. So, what is the difference between dish and expand? So that's something that you could easily get up. They'll show you a picture of someone with dish, and they'll say, right, tell me the features. So one of you is going to tell me the features of dish. One of you is going to teach me the features of expand. So who wants to do dish?
So dish tends to be in older patients. There's an association with diabetes.
Yeah.
There's no genetic inheritance to it, as there is with Axpon.
Mm-hmm.
The radiographic features are non-marginal syndesmophytes, so flowing candle wax style appearance.
Yeah, so this is dish. So you've got really big osteophytes coming out the front, okay? Yeah. So they're called non-marginal osteophytes.
Characteristically, they are often spared on the left side of the spine, although it can be and you don't have any SI joint involvement, which you do with the other condition.
Okay, so this is a marginal osteophyte, so it's on the margin of the disc. Okay, so it's like a very thin line here on the edge of the disc. Okay.
The Angst is an inflammatory condition that's usually associated with young people and is more common in males. People with ankylosing spondylitis have a higher rate of having HLA-B27, but of the whole population that have HLA-B27, not everyone has ankylosing spondylitis. It's associated with marginal osteophytes and a bamboo-like spine and sacroiliitis.
Okay. Yeah. Does that answer who you asked that? Yeah. You happy? So that's the sort of thing. In Miller, there's even a table and a picture. I can't even remember what was in the table and what was in the picture, but there is literally like this and addition and expand, isn't it? Because it's just like what they're asking. Okay. Okay. Next one. Okay, who's doing this one? Where are we up to? Yeah.
So 71-year-old female with L2 compression fracture with some loss of height and kyphosis, but I think given that deformity, it'd be reasonable to manage her with analgesia and mobilization.
Yeah. So again, old lady, it's a minimal. Remember I talked about 20 degrees of kyphosis, 50% height loss, so it's well within that, okay? So oral pain medications, thoracolumbar orthosis, and increase the activity. Happy? Cool. That's it. Your weekend starts now. You guys all good at Cambridge Army?